Okay. Good morning, all. We'll be continuing with our blood culture discussion for the day. Case number one, we have a 78-year-old female who's having fever for the last 15 days associated with chills and rigor. Flank pain is there. For the last 10 days, she has burning micturition, altered sensorium. So with this, it is going towards complicated UTI diagnosis. It can be urosepsis. Also, there's history of cough for 2 days. There's decreased responsiveness for the last 6 hours, and that is why they bring her to the hospital. She's a known diabetic and hypertensive for the last 30 years. The history of analgesic abuse 10 years back. On examination, there is renal angle tenderness and left infrascapular crepes are seen. So they diagnosed this case to be septic shock due to urosepsis, aka on CKD. So these are the vitals of the patient. Urine output is maintained, but you're able to see temperature is elevated and she's not maintaining saturation in room air. So she's being given supplemental oxygen. Her BP is maintained on noradrenaline. So here you're able to see the blood culture sample was sent on 2nd. So at the time when the blood culture sample was sent, you're able to see there is leukocytosis, which is neutrophilic. You're able to see the RFT is grossly elevated. Creatinine is 6.1 with high potassium levels. There's hyperkalemia in this patient. You're also able to see the urine routine of this patient has pustules.
High blood urea also.
High blood urea also. And in this case, you're also able to see the albumin is mildly decreased. So coming to our blood culture report, which is sample sent on the 2nd, here we've got Escherichia coli, which is a ESBL plus AIIMS producers. So here you're able to see the BMQ comes out good for meropenem and amikacin. That is what we have suggested here, both to be given separately. So coming to our urine culture report of the same patient, we get the same organism with the same antibiogram. So now the source for this organism in the blood is found. So the patient has a creatinine clearance of 7 ml per minute, which is grossly decreased as a result of her creatinine of 6.1. So the USG abdomen, this is an interesting thing which we have to keep in mind. You are able to see that there is no perinephric collection, there is no evidence of any pelvic calyceal dilatation, there is no obvious collection noted in the renal parenchyma. So whenever a patient presents like this, we usually send an ultrasound abdomen to rule out any collection, to rule out pyelonephritis. So in this case, the scan says that there is no pyelonephritis, but all the other tests and all the other clinical features point towards a complicated upper urinary tract infection. So this point we should always keep in our mind. Ultrasound is insensitive to changes of acute pyelonephritis, with most patients having a normal scan. So abnormalities are only seen in around 25% of the cases, and these are the possible features that can be seen as abnormalities on your USG scan. Especially useful for gas producing agents where emphysematous pyelonephritis, you will be seeing gas bubbles on the scan. So this patient was treated with piperazine tazobactam 4.5 grams IV stat followed by 2.25 grams TDS over 3 hours. So again the correction was done for hyperkalemia. They gave calcium gluconate, insulin in 25% dextrose, sodium bicarbonate and astalin. And the vasopressors were given to maintain the mean arterial pressure. So this patient went against medical advice. So we don't have a follow-up of what happened to this patient. So whenever creatinine clearance is less than 20, we have to lower down our dosing of piptas from 4.5 to 2.25 grams TDS. So in this case, our creatinine clearance was 7. So this is an article from JAC, antimicrobial resistance, where they're looking into optimization of antimicrobial dosing in patients with AKI. So we always have this conundrum, right? Patient is in AKI, Is it okay if we give a nephrotoxic agent? Is it okay if we give a nephrotoxic antibiotic? Is it okay if we give the higher dose of the agent? So in this article, they found out that dose adjustments of beta lactams may not be necessary in the initial 48 hours of infection induced AKI, and single dose aminoglycoside can also be added in addition to that as an early empirical cover. So because in sepsis there can be augmented renal clearance in some cases. So here they tell us you needn't change your beta lactam dose. Empirically you can also add an aminoglycoside dose. So how have they described this? This is a graph showing patients who have received full dose of aminoglycoside, half dose of aminoglycoside and nil aminoglycoside. So you're able to see the patients having a full dose of aminoglycoside. The serum creatinine is in millimoles per liter. So normal serum creatinine will be somewhere between 53 to 106. So from the increased points, they come back into this bracket. Even your full dose aminoglycosides, they come almost at the same time. So giving an empirical dose of aminoglycoside is not going to interfere with your renal function of the patient. So this can be used as an important empirical strategy in treating complicated upper urinary tract infection.
Post 48 hours it has to be corrected.
After
48 hours. So going to our case number 2, here we have...
So even if there is an AKI which has been induced by the infection, so for the fear that we might induce further nephrotoxicity, there are chances that the clinician may not give aminoglycoside thinking that it's already infection-induced AKI. So that fear has to be overcome, and they have to start OD aminoglycoside like a normal standard dose in the first 48 hours, and then again remonitor the creatinine and then decide later.
Yes, by then we would have got the culture report, sir. So with that we can escalate or de-escalate. So the main 2 takeaways from this case would be that even an acute pyelonephritis case can have a normal picture on ultrasound, and the addition of aminoglycosides as an empirical therapy and continuing with the standard dose for beta lactams when it comes to empirically treating a case of acute pyelonephritis. Moving on to our next patient, we have a 56-year-old male who comes with fever on and off for 1 month. He has chills and rigor, again is associated with decreased urine output in this patient, has dysuria, pyuria. This history of chronic penile abscess with purulent discharge. Patient is again has uncontrolled diabetes mellitus, is hypertensive, has coronary artery disease, post status PTCA, has chronic liver disease, an alcoholic and a smoker. Point to notice, he has a suprapubic catheter in situ, which is done 11 days back. So with respect to his comorbidities, he had, as he's a liver disease, chronic liver disease patient, he had esophageal varices as a result of portal hypertension, for which esophageal varicose ligation was done a year back. So PTCA was done for the CAD, and 3 months back, as a result of his benign prostatic hyperplasia, transurethral resection of prostate was done and Foley's catheter placed in situ. He had an abscess on the shaft of the fever. Again, we saw the patient has uncontrolled diabetes. And IND was done 2 months back. Now he has presented to our OPD with mainly shortness of breath, fever, micturition and respiratory distress. So initial evaluation, you are able to see the BP is very high. On local examination, you are able to see the spinal edema with multiple discharging pus points. Even though an IND procedure was done earlier, he's again developed penile edema and multiple discharging pus points as a result of his uncontrolled diabetes. You are able to see the suprapubic catheter in situ, the suprapubic tenderness. Evaluating the patient further, bladder decompression and irrigation was done. The suprapubic catheter was changed. The patient was on intravenous antibiotics. They actually started him on meropenem and they resuscitated him with IV fluids carefully because his blood pressure was also high. After some time, the patient's neurological status and respiratory status fell by. Initially, his respiratory status was not very bad, but as he progressed, he went into respiratory distress, which necessitated endotracheal intubation and mechanical ventilation. So the patient was continued on a vasopressor support in the form of noradrenaline for a septic shock. Mechanical ventilation and renal replacement therapy was done. We were waiting for the AST for this patient. This all happened over a period of 1.5 days. The patient had lactic acidosis, his renal parameters worsened, his inflammatory markers like procalcitonin increased. So on the early morning of 8th, he went into cardiac arrest. In spite of resuscitation efforts, he succumbed. So what organism we got here? So on the day, on the 9th of the 6th of January when he came by, the blood culture was sent. There's a carbapenem resistant Klebsiella pneumoniae. 2 samples were sent. Both grew the same organism. Ceftazidime avibactam and astronam, individually they were resistant, but when the synergy test was done, synergy was present, but he didn't receive that drug. He was only getting meropenem. So here you are able to see again this patient has leukocytosis, which is again a neutrophilic. You are able to see on 6th when the RFT was done, serum creatinine is 4.1, and again you are able to see in this patient the albumin is low with an elevated ALP.
How many doses of Septa he has got?
He's got no doses.
Nothing.
So again here in his urine routine, you are able to see that there's pyuria. You are able to see again his HbA1c is not controlled. Serum procal is highly elevated, 7.1. He's having acidosis. His PTINR are also elevated. His urine culture, unlike the other case, his urine culture came out to have 2 or more type of organisms. This is the result of the penile edema and the draining sinuses there. He couldn't have given us a sterile sample. So again, this is also a case of pyelonephritis, urosepsis complicating, entering into the bloodstream, causing MODS, affecting the lungs, affecting the central nervous system. So this is a document published just 6 months back by IDSA for complicated urinary tract infection. It gives us a stepwise algorithm as to how to choose an empirical antibiotic of choice and how long to give them. So they have also given this new classification and definitions for complicated UTI, which means infection beyond the bladder in women or men. Can be pyelonephritis, can be febrile or bacteremic UTI, can be a catheter associated UTI, and it can be a prostatitis component in the UTI as well. So all these things will be classified as a complicated urinary tract infection. So now coming to our 4-step approach to choosing an empirical antimicrobial agent. This is again from the same document. So first they are asking us to assess the severity of the illness. So that is the first step that we always have to do. The recommendation which they give is for patients with suspected complicated UTI, we suggest that the selection of empirical antibiotic therapy be initially guided by the severity of illness, specifically by whether the patient is in sepsis or not. So that is what they say. And to diagnose sepsis, we have a sepsis 3 task force definitions where we make use of a SOFA score increase in more than 2 points. So it should be a risk-based, severity-based assessment. So that is your step number 1. Your step number 2 will be your patient-specific risk factors for uropathogen. So example, in our case, he already had an existing catheter in situ. He already had a lot of comorbidities. He had a local comorbidity, also had a systemic comorbidity. So we have to focus at patient-specific risk factors in this case. Third will be we have to evaluate risk factors for the resistant organisms. That will be our third. And fourth will be our access to our antibiogram. What is our local antibiogram? What is the resistance and susceptibility percentages per se? So I've actually mixed up second step and third step, but these are the 4 points which we have to follow.
So this is exactly what even the last step. This is also what your N39 document also suggested. That whenever you are suspecting a complicated infection, whether it is a complicated UTI or because by default meningitis is on its own a complicated infection. So in that case, you have to consider those antibiotics for which the susceptibility is more than 90%. Otherwise, it is not a very complicated infection which can be managed not in the ICU, maybe in the ward only. So in that case, you can lower the threshold to 80%. But unfortunately, like most of the CRE and all these infections, we won't have. So by default, you have to go in for a Cept-IV aspirin combination with suspecting a parent regression organism. So like many times we don't, even if we are not testing for the NDM and oxals with our rapid test, still we go in for a Cept-IV aspirin combination only. So this is as per the CLSI only, the last step that they given, the 80%, 90%.
So an easy way to remember these 4 points will be, the first will be the disease, which is the severity. The second will be the patient risk factors. Third will be the organism's resistance. Fourth will be the hospital antibiogram. The easy way in which you can remember all the 4 points. So following this, what do they say? What are the potential empirical antibiotics we have from which we can choose from? So if a patient is having sepsis with or without shock, they're saying you have a third or fourth generation cephalosporin, you have a BLBLI agent, you have a carbapenem, you have a fluoroquinolone, which is preferred usually. Alternative, again you have all just as we discussed, ceftazidime, avibactam, aztreonam like combinations which are novel agents. Without sepsis, there's no sepsis but you still have an IV access, so then again you can go for third, fourth generation cephalosporins, BLI combination and fluoroquinolone. So here they have removed carbapenem. So they've gone for a carbapenem sparing option as a preferred, and they've transferred that carbapenem into the alternative option. If this can't be done, then you go here. So only in the sepsis with or without shock you go. If there is no sepsis, you try to go for a lesser antibiotic. So if there is no sepsis and only an oral agent can be given, you can go for cotrimoxazole and fluoroquinolone. So again, another thing to be very much strict here is nitrofurantoin and fosfomycin should only be given for lower UTI, shouldn't be given for complicated upper urinary tract infections.
One more thing was that there is a step in between piperacillin tazobactam and carbapenems. Yes, if it is a high inoculum infection, or if it is a complicated infection, yes, piptazo, despite its susceptibility, should not be used as monotherapy. If it is a low inoculum infection, uncomplicated, maybe you can use piptazo as a monotherapy as an extended infusion. But if it is somewhere little higher and you want to still spare the carbapenems, then that's the reason why we on our report we write amino glycoside plus piptazo. So that's the step in between shifting from a piptazo monotherapy to a carbapenem monotherapy is to add a amino glycoside in between. And if that also does not respond, then shift to carbapenem and try to restrict the use of carbapenem as much as possible, because among the two major ones that we have got, we can only rely on meropenem, not even on meropenem because of its induction potential.
So here again, amoxicillin, they kept it only as an alternative. We are not going to use it as a first line.
The day before yesterday also in one of the talks I said that what I would prefer is that to just use imipenem as more of a diagnostic disc rather than a therapeutic disc. That's the reason why I put it in center to see the induction. Otherwise, it has got a seizure potential. It has got an induction potential. So I feel that it should be shifted more towards being used as a diagnostic disc rather than a therapeutic disc. Like that, and yeah.
So coming to the duration of complicated urinary. So usually in our traditional approach, we think, okay, lower urinary tract infection 5 to 7 days, complicated UTI bloodstream infection, we have to give for 2 weeks. But here the recommendation says that if you're going to go for a non-fluoroquinolone, which is a beta-lactam based therapy, a 7-day treatment will suffice, and the same applies to a fluoroquinolone based regimen also. The important thing to note here, a caveat which has to be looked into is men with febrile UTI in whom you are suspecting or who have bacterial prostatitis, in those people you may have to give up to 10 to 14 days. 7 days may not be sufficient. So even up to 14-day regimen may be required. This is their stepwise algorithm for an IV to oral switch. If the patient is clinically improving, you assess for oral option, switch to an oral agent, treat for 7 days. If he is not clinically improving, assess for the drug bug mismatch, look for intrinsic resistance, look for PK/PD parameters, look for a drug which will concentrate well in the urine. So assess for an unresolved source. If you are missing out of any other extra renal source, reassess the diagnosis of complicated UTI and plan for a longer course. So if it's an extra renal course as we saw in prostatitis, so that has to be treated for a longer duration. So coming to our third case, this is a 73-year-old female who's been diagnosed with serous cystadenomas of the pancreatic head. Now she's POD 40 after Whipple surgery. She's a diabetic and a hypertensive. The procedure was done on the 1st of December. She was discharged on the 19th of December. The in-between period was unremarkable. When the procedure was done, 232 French abdominal drains were placed, one in the lesser sac above the pancreatico-jejunostomy site and one in the subhepatic space below the hepatojejunostomy site. A nasojejunal tube was also placed in situ. The reason for mentioning these drains is as follows, because again on the 6th of this month she starts to develop fever. It's again recorded at 104 degrees Fahrenheit, for which she comes back to our hospital. So in the hospital they remove the PJ drain and the NJ tube. So from the HJ drain and 1 to 1.5 ml of fluid, they were able to get an yellowish turbid metal, but because of the paucity of the sample they couldn't send that fluid for culture. So this is the CECT abdomen pelvis when the lesion was diagnosed before the surgery. So you are able to see the cystic neoplastic lesion of the pancreas. This is in November, way back in November. You are able to see the cystic neoplastic lesion involving the head of the pancreas. So this is again early in December. This was right before the day when the surgery was done. So an intra-bile fluid sample was sent. It gave us no growth. So this is the scan which was done in view of any intra-abdominal collections. They did a CECT to find out if there's any intra-abdominal collection, if there's any active collection which can be drained, but there wasn't any intra-abdominal collection. Another thing to note here is you're able to see the patient's left kidney is small compared to the right kidney, so that has to be further evaluated. The patient also has mild hepatomegaly. So when she developed fever, when she was readmitted to the hospital, again you're able to see this patient is having leukocytosis, it's neutrophilic. Serum procalcitonin is highly elevated, 66.6, like the devil's number. CRP is highly elevated, 384. So from 6th, the problem with this patient is that the patient was started on piperazine tazobactam and metronidazole even after advising multiple times. So on 9th, the TLC came down, but the patient's HB and other parameters were also a bit deranged. So coming to the patient's RFT, serum creatinine again deranged, 1.8, sodium levels were also less. So they were thinking of some systemic infection. Again in this case you are able to see the albumin is low. So the blood culture sent on 6th, 2 samples were sent, both flagged for Escherichia coli. Again it's an ESBL plus AIIMS producer. You are able to see here are cefotaxime plus cefotaxime clavulinate. So cefotaxime gives a zone of 8, cefotaxime plus clavulinate gives us a zone of 10. If this was a pure ESBL, it would have been more than 5 mm. Since an AIIMS component is involved, that is inhibiting this clavulinate part. So here you are able to see again we've given ertapenem as an OPAT option. We've given piperazine tazobactam as an option for this patient inside the hospital along with gentamicin. So here in this case we can actually go for a carbapenem sparing option. Another thing which if there can be another school of thought where okay I want to address this situation based on BMQ reports. That case, what can we do if you have a situation where a carbapenem can be used? If you see the BMQ for meropenem is 1 divided by 0.25, it is 4. It is higher than what there is for piprazolam tazobactam. Piprazolam tazobactam is only 2, whereas for meropenem it is 4. So people who strictly stick to BMQ, they will say meropenem may be a better option.
Reason that normally we keep amikacin for intravertebral, genta for gram positives, netlomycin for acinetobacter, and tobra for Pseudomonas. In this case, you see, I think yesterday I told Parvati also, the reason we're giving, despite the BMQ of Amica and Genta both being the same, if you remember I texted you yesterday, we're giving Genta because this 1 is not just 1, it is less than 1. So it could be 0.5, so that BMQ could have been 4 also. So that's the reason why, because as per White, because the Amikacin MIC is the absolute number, it's not less than 2 or more than 2 like that. Because the absolute MIC as rated by White, so that's why that BMQ is the absolute BMQ for amikacin. Whereas for gentamicin it can be 2, it can be 3, it can be 4 also. Because it has not detected the lower limit of genta, because that's where till the projected MIC of White will go for genta. So that's why that less than 1 is specifically added just to tell that that MIC is the BMQ can be 2 or less or more than 2 also. So that's why next slide. And that's why we're giving gentamicin and piptazone.
Yes, sir.
Right. And one more thing is that if you do the combination antibiograms in such case, you will find that in the combination antibiogram, piptazone and amikacin, piptazone and genta probably might be faring better in the enterovaccillus as compared to monotherapy of meropenem. So that we can always sit and discuss, because I have calculated the combination antibiograms also using the WHO rate. We found that piptazone, genta and piptazone mica almost to like 98% to 97% susceptibility given as a combination therapy. So that combination antibiograms also we can make on WHO rate. So that also we will discuss in the workshop.
So as we discussed, this patient received piprazolam tazobactam plus metronidazole, so there was redundant coverage. After that, after we said metronidazole was stopped.
So one more thing is interesting that recently I came across is that among the beta-lactam drugs and the BLBLA combinations, if we have to choose as an anti-anaerobic agent between piptazone and meropenem, the chances of bacteroid, which is a predominant anaerobe, developing resistance is least for piptazone. So the maximum chances that that any of the other BLBLA combinations or carbon might fare better over anaerobes is piptazone as compared to meropenem, and cefepime in any case does not have any anaerobic activity. So that's why, yes, it is a redundant coverage, it's a double anaerobic coverage not required. They could have stopped metro, not needed.
So this patient had a creatinine clearance between 26 to 50. So if the good thing with piprazolam tazobactam is that if it is less than 20 only, we need to go for a reduced dose. If it is more than 20, it can be 20, 30, 40. Respective of that, you can go with your 4.5 gram TDS dose. But when it comes to meropenem, when your creat clearance is between 26 and 50, you have to go for a 1 gram BD dose. You can't go for your 2 gram TDS dose, you can't go for your 1 gram TDS dose, you have to go for a 1 gram BD dose in this case. So coming to another paper with specifically respect to pancreatoduodenectomy. So this is what they do in Whipple's procedure. So based on the systematic review, the period of prolonged prophylaxis was not standardized across the included studies. The duration varied significantly. So prolonged prophylaxis shows promise for patients with pre-operative biliary drainage. So if there is some collection and pre-operatively they have done biliary drainage and then they have done with the Whipple's procedure or pancreatoduodenectomy, those patients it is better to go for a extended period of post-operative prophylaxis. What they are trying to say is initially before our surgery we give our surgical prophylactic dose. So in these cases what they say is up to 24 hours after the procedure is done, give 1 or 2 more doses. This decreases the rate of post-operative in surgical site infections, especially when a prior biliary drainage procedure has been done, because that bile and that organisms there, they tend to colonize that area and cause infection. So what they are saying is they are welcoming RCTs to make sure that standard recommendations for such procedures are like we have a umbrella prophylaxis when it comes to surgery. There are few specifications when it comes to implant procedures for breast surgeries, especially when it comes to surveillance. But for specific surgeries, if we can come with the protocols, it will be even better. Here there is another Indian study released in October 2025, where again they specifically looked into Whipple surgery, antibiotic preferences, post-Whipple surgery, microbial landscape and sensitivity profile analysis. I don't know how much sir will accept this, the finding of this paper, because they have given preference to cephalosporin sulbactam over piperacillin tazobactam. They have said that their complications, post-operative complications occurred in 47.7% of the patients, more frequently among those with positive bile cultures than those without. So they're saying in the cephalosporin sulbactam group, 38.9% had complications, whereas in the piptaz group, almost 90% had complications in their study. Their number was around 65 over a period of 3 years, 2022 to 2024. Around 60 surgeries of Whipples were done. They saw a better outcome with respect to a 30-day mortality and morbidity. It was better with cephalosporin sulbactam, as again cephalosporin sulbactam also has anaerobic coverage. The downside to cephalosporin sulbactam is we do not have CLSI breakpoints for cephalosporin sulbactam.
Anything we don't have breakpoint, neither CLSI nor UCAS nor FDA. Again, the same thing that this issue was addressed in this microcon by the CLSI team also. That the reason is that because the original manufacturer has not submitted the breakpoints to FDA for validation, because this exists as two doses, Magnex and Magnex 4. So in this one, the other case, they increase the cephalosporin component also in that fourth thing. So you can't have, and they are not submitted. So it is not a bad drug, it's a good drug, no doubt about it. But then legally, I don't have any parameter to make me decide whether to submit it as susceptible or not. Just because one company or one machine shows that it is susceptible, so there are no existing breakpoints which are cleared by the FDA. So that's the only legal reason we can't report. Otherwise, it's a good drug, effectively, no doubt.
So coming to our next case, we have a 72-year-old male who's admitted for an acute ischemic stroke, cerebrovascular accident, the MCA territory, left side, who's been thrombolized with tenecteplase. He also has coronary artery disease. He had an episode of aspiration pneumonia, had pulmonary edema and ARDS. He also had a scrotal ulcer, and he's been tracheostomized. He has ventilator-associated pneumonia and bloodstream infections with multi-drug resistant organism. So this is the outline for this case. He has a long stay at our hospital. So I'm just going through the positive blood cultures of this patient and what we have got now. So starting, I'll go in chronological order. 10th of December, we grew an ESBL AMC producing Escherichia coli. Patient was on meropenem and amikacin. A week later, he grew Spingomonas possimilibus and Schwannella putrescens, only one out of the two cultures, so it was deemed contaminants and was not treated. On 17th, the urine culture was sent, which had no growth. On the 18th, the ET aspirate was sent, which grew crab, for which polymyxin B and minocycline was started. The patient also had a scrotal ulcer, which had a necrotic patch and had a few pus points which were foul smelling. The sample for which was not sent, we were afraid that the patient may develop Fournier's gangrene and was started on piperacillin tazobactam, vancomycin for MRSA coverage and clindamycin for the antitoxin coverage. He was also given Neosporin plus topical ointment. Now coming to the later part of December, where the bug which were isolated from the blood and endotracheal aspirate, the endotracheal aspirate sent on 24th of December grew carbapenem resistant Klebsiella pneumoniae. So now that crab infection had gone, the patient's chest x-rays were also improving. The patient's CPIS score was also decreasing, but then he developed a CRKP infection, for which they didn't start treatment on 24. They were waiting for okay, this can be a colonizer because CPIS score is decreasing, chest X-ray is improving. But on again the 2nd of January, the blood culture sent grew the same organism with the same antibiogram, carbapenem resistant Klebsiella in all 4 bottles. So now they had no other choice but to start treatment with ceftazidime avibactam aztreonam combination, which the report said which had synergy. So this is the report. You are able to see that everything is resistant. For this patient, the ceftazidime avibactam aztreonam synergy was positive. The patient was started on 2.5 grams ceftazidime avibactam and 2 grams of aztreonam 3 times a day over 3 hours. So here you are again able to see the patient's bilirubin was elevated on the 2nd, and later on the 6th you are able to see that the bilirubin has gone down, but the AST and ALT has increased. So here we are again looking at a potential case where this can be a drug-induced liver injury because PT-INR are also elevated borderline. So can ceftazidime avibactam aztreonam cause a drug-induced liver injury in this case? Can we straight away deem it as drug-induced liver injury? So we have this guideline, EASL guideline from 2019, which gives us a grading system as to how you can grade an event into mild, moderate, severe and fatal drug-induced liver injury. There are common drugs, anti-infectives, which can cause drug-induced liver injury. Our patient fell under the category of mild drug-induced liver injury, and we also have guidelines as to when to withhold the drug. So these are the following parameters. Say an ALT or AST of more than 8 times upper limit of normal, or an ALT or AST of more than 5 times upper limit of normal for more than 2 weeks. So ours, that wasn't the case. So we have such guidelines as to say when to stop the drug immediately. These are all from clinical trials and not post-marketing data. So a stepwise approach towards drug-induced liver injury would be like you have to look at the probable triggers. You go through the chart, look at patient is having any alternate medicine, herbal medicine, what he's eating. There have been cases of people developing drug-induced liver injury only by drinking green tea. People go on such fat diets, drink only green tea. There are such hepatotoxic compounds in such agents. Patient ends up in a DILI. Here we did a R score to look for whether the patient's pattern was a hepatocellular pattern or a cholestatic pattern. Ours turned out to be a mixed pattern of 2.4. Here in this time you should evaluate other causes of the liver injury also. You can send your viral markers, you can look for a vascular cause, you can look for a biliary cause. And if needed, if you are not able to come to a conclusion, there are certain indications where a biopsy is warranted, like autoimmune hepatitis, acute or chronic atypical presentations of hepatic vascular disorders, chronic hepatic fibrosis and microvascular steatosis. So this again is a paper which is released this year in 2025, looking specifically at the safety profile of our ceftazidime avibactam aztreonam, because as a last line, like how colistin used to be there 10 years back, now ceftazidime avibactam aztreonam combination has become like that. So what is the safety profile of this patient? And these infections we usually tend to treat for a longer time. So coming to this, they said the most frequently observed adverse event were hepatic aminotransferase elevations. So as seen in our case, so ALT, AST elevations are the most commonly seen ones. In this study, 2 subjects with the aztreonam continuous infusion cohort, they were the people to get severe ALT, AST elevation. This is specifically for the 6-hourly aztreonam dosing. So whenever you're advising a 6-hourly aztreonam dosing, always be aware if the patient already has other comorbidities, better to go for a 8-hourly aztreonam dosing. So if ceftazidime avibactam is prescribed, we should always monitor the liver function, hematological function and other coagulation parameters, PT-INR, LFT, CBC, they have to be monitored. So coming to our 5th case, we have a patient who is a chronic liver disease, has hepatic encephalopathy, is a 70-year-old female, has severe anemia, suspected community acquired pneumonia and severe hypoalbuminemia, has also developed metabolic acidosis. regarding her decompensated chronic liver disease, 4 years back she has it for 4 years, and she had a UGI bleed back and had grade 2 esophageal varices, has portal hemorrhagic gastropathy, has abdominal distension, swelling of legs, constipation. All this comes under your decompensated liver disease bracket, has decreased urine output. Coming to the community acquired pneumonia component, she has history of cough associated with expectoration for a week. She mainly came for the history of shortness of breath, which was already there for a year, but it increased to MMRC grade 3 over the last week. Over the last week, her abdominal distension also increased. So this can be interrelated also. The increased abdominal distension over the last 1 week is causing the increased shortness of breath during the same time period. She has altered sensorium and has respiratory distress also. So she had some ECG changes also. For the fluid collection, the diagnostic paracentesis is done. The ascitic fluid showed an elevated lymphocyte count, but it didn't grow any organism. Spontaneous bacterial peritonitis was ruled out. So the organism which we grew here was a carbapenem resistant Acinetobacter baumannii. Out of 2 samples, we grew only 1 sample. The patient's tracheostomy, CPIS score of this patient is only 3. So they have not yet started treatment for this patient. Our report is also in the preliminary, only flagged the day before. So yesterday only we got the ID. The direct AST also shows meropenem resistant. So this is a carbapenem resistant isolate. So contrastingly, but the patient's CBC count shows leukocytosis. Procalcitonin is in the borderline. Usually 0.5 we take it as a cutoff, but in this case again the CPIS score is less. It is borderline. They've still not yet started treatment for this patient with the polymyxin B or minocycline or ampicillin. So patient is on vasopressor support. He is on meropenem and azithromycin for the community acquired pneumonia because of the interstitial pattern on the X-ray. He's being managed for the hepatic encephalopathy and anemia. He's getting drugs like rifaximin, Udlib. So he also is getting discharged against medical advice because of financial constraints. So coming to another scoring system with respect to stratification for carbapenem resistant Acinetobacter baumannii, we see in our ICUs whenever we have a CRAB patient, when we report a CRAB patient, what they do in isolates all CRAB patients, they bring them together and they make it a CRAB corner. 2-3 patients together, they make it a CRAB corner. So how do we go about this? So this is a scoring and a stratification system for it. So mechanical ventilation days 2 points, prior carbapenem exposure 1 point, and hospitalization of more than 14 days 1 point. So if you get a score of 4, you definitely have to go contact isolation. If it is 2 to 3, you can order for a preemptive culture. If it is 0 to 1, standard monitoring will do. So this CRAB RSS score, it was done from a single center. If it is done from a multi-center, we will get better results. Thank you.